Jolene.
Hello, Jolene Crone, Deputy Administrator Clinical Director with Salish BHASO. I'm trying to think what's relevant here. We have transition in our organization. Our administrator is leaving us December 1st. Officially, her last day will be the 21st of November, her last working day. So we are in the process. They have done interviews for her replacement, so things are moving fairly swiftly in that area. We are continuing the development of the SYNC program, the Salish Youth Network Collaborative, and are continuing to recruit for the supervisor replacement for that team. But they are active and actually starting to get referrals, 8 or 9 total now. So we are moving forward. We have a bunch of naloxone that we've been ordering. So we have 10 naloxone vending machines that we are looking to place across the 3 counties. So we are doing some work to determine who is interested and where we may be able to place those. So far, we have had some interest from Kitsap Transit and from Quileute Tribe, as we are 3 counties. So if there is anyone in Jefferson who would be interested, please send them our way or reach out and we can help coordinate that as well.
We'll definitely reach out on that. Thank you.
Absolutely.
Thank you for being here. Commissioner Brotherton.
Hello, Greg Brotherton, Jefferson County Commissioner, and excited to see you all. I don't have a particular big update, just, horrible to lose Stephanie from Salish Behavioral Health Administrative Service Organization, and tough to lose Derek Kilmer as well. So I'm just thinking about transitions right now.
Yes. We've got a lot to cover in today's meeting, so I'm going to finish up our introductions, but keep it as tight as you can. Brett Englund.
Brett Englund from JCSO, helping with the data right now. I just sent you an email on the issue on the data, so you might want to look before we start. All right.
Okay. Yvonne.
Hi, everyone. I'm Yvonne Owen with Olympic Community of Health, and I do not have any updates, just here to listen.
Thank you. It's nice to have somebody from OCH at the hearing everything that's going on here. Chief McKern.
Cool Scene Fire Rescue, only update we have. Anya, thank you. You continue to fill up our Narcan boxes, and Jolene, please bring another one to Cool Scene. We're tired of being the only one up in Cool Scene, and that box is going up through it fairly rapidly. And for the folks there at OLICAP, if we can get those mounted on the Brennan and the Cool Scene Center, that would be amazing. And what do you need? Oh, and I work for Dr. Carbaum. Just so you know, actually, Dr. Carbaum is the most amazing guy at most of the meetings that we have with Northwest Region. And you did, I think, did you mention West Olympic? Did you forget Forks? I think.
What's that?
I think, did you forget Forks? That's also in the region as well. West Olympic, I don't know if you said West Olympic or not. So sometimes that we forget that little corner of the piece out there, which is partly Jefferson County. So with that,
I just assume they're part of us.
That's very true. They probably are.
Thank you, Chief McKern, and we'll follow up on getting those boxes up. Cassidy.
Hi everyone, Cassidy Chang from Jefferson Healthcare. No big updates to share. Thanks.
Thank you for being here. Andy.
Hi everyone, Ann Dean, Discovery Behavioral Healthcare, and the only update I'm going to share is that we have a brand new website at www.discoverybh.org, and we'd love it if you'd check it out. That's all. Thank you.
You should go ahead and drop that link in the chat box.
Will do. Good. Thank you, Lori.
But wait until we've gotten through the data. We don't want to distract people because it's so pretty. Anya.
Hi, Anya Callahan with Jefferson County Public Health, doing the harm reduction coordinating. And thank you you, Chief McKern, for keeping those boxes, helping coordinating to keep those boxes stocked. We bought 10 boxes maybe 4 or 5 months ago now. And all the boxes have been spoken for. I just met with the Port Townsend Library this week, and they want to put one up. And we have one up in Hadlock Library already. So we're planning some community trainings, potentially with Port Townsend staff and employees of Port Townsend, and then also with like the library and public facing. So if there's funding to buy more boxes, I think we could buy 10 more. I've heard from folks at Ollycap and Dove House that they would want some up in some of the housing spaces that they have. So yeah, let's get more boxes. I'm really excited to hear from Jolene about the vending machine. So I'd love to support, getting that out and helping with education and things around that. Thank you. That's all I have for today.
Such great work you're doing out there, Anya. Thank you. Lori Tinker.
Hi, Lori Tinker. I am presently, for about the next 28 days, the chair of the EMS Council, and I serve with the pleasure of Chief McKern and Dr. Carlbaum, and I really don't have anything to add today. Thanks.
Thank you for being here, Lori. Jim Novelli.
Jim Novelli, Discovery Behavioral Healthcare, and I won't say anything just to keep it short.
Thank you. Good to have you here. Lisa Grundle. You know what? I'm going to give Lisa a moment.
Sorry, that's okay.
Okay.
Brett has me distracted. Brett. Yeah, I figured out what I did. But anyway, yes, I'm working on the data. Hopefully this will be the only error that's found out. Brett and I have been working through this today. So that's the combined Brett, by the way. So anyway, I have been working on the data. It's been really fun and exciting. And we have 3 full years of data for a lot of you now. So it's kind of fun to look at. So lots of different ways you can cut it. And I'm trying to scramble to fix Brett's right now. So anyway, nice to be here. Thanks.
Good to have you here. And I just wanted to underscore, Lisa and her team have done so much work toward today's presentation. I'm really excited to see this milestone after all of these years that we've been collecting. This is a great moment, and then it'll also set the tone kind of for what we want to do going forward. Apple.
Hey everybody, nice to see you. I'm Apple Martin. I'm the director here at Jefferson County Public Health, and I'm eager to see the data too. There's always so many things going on at public health. I think I'm just going to not say any of it because I want to save the space. But suffice it to say, collaborations with you folks and all kinds of partners doing some really innovative, new sort of cutting edge stuff with public health is really invigorating for me. I feel like public health is having a little bit of a rebirth after a really long 3 years. So anyway, I'll stop with that and wait to hear what's coming next.
It's very exciting, Apple. Thank you. Barb Jones.
Hi all, I am Os from Jefferson County Public Health, and I am with the CHIP program. So thanks for having me here today.
Good to have you. Adam.
Hi, I'm Adam from data analyst from Jefferson Healthcare. Since the last meeting, I don't have any super exciting things to report that would be too relevant here. So I'm going to pass on that and save our time. So.
All right. Thank you, Adam. Good to have you here. Gabby.
Gabby Caudell, the clinical director of Believe in Recovery and Gateway to Freedom, and I will also keep it short and pass on introductions.
Thank you. Lindsay.
Hi everyone, Lindsay here with Substance Use Prevention at Jefferson County Public Health, and I'll keep it short, but we had medication take-back events last month, and this month we're hosting a parenting workshop, and if you want to know more, you can talk to me about that, but it's good to see you all. Thanks, Lori.
Thank you. Thank you for being here. Rebecca.
Hi, Rebecca Marriott, Therapeutic Course Coordinator. Glad to be here. Nothing big today.
All right. Thank you. Well, today we are going to go through our the data analysis and some insight generation, which is not necessarily the insight, but we know what the data we have tells us. The question is are we discerning the right message? Are we collecting the right thing? And to walk us through that, we have Lisa Grundle from HFPD, whose team has been doing all of the work on the analysis that you're about to see. And Lisa, I can run the slides from this side, or you can run them from your, whichever is easier. You might be on mute.
Sorry, I'll blame Brett again. He has me distracted.
Brett.
Sorry. Brett, no. Yeah, having you do it would be great, I think. That would be great.
Okay. All right, let me just quickly share.
Well, if you prefer, I could pull it up too. So
no, if you had changed anything, I just didn't want you to feel like I had the wrong
oh
thing.
no, I made notes. I'm gonna have to just explain what we did with Brett and get a new one out. So
all right then. I've put also links to the meeting packet and the Padlet in the chat. And here's what I'd like to say, because we've got so much that we're going through, I would like us to give Lisa a chance to get all the way through her slides. If, as we're going through, you have questions or thoughts, insights that you'd like to share, go ahead and put them in the Padlet. There's a column there where you guys can all add comments. And then we'll go back afterwards, after she's gotten through the whole presentation, and sift out the questions and take our discussion from there. So with that, I'm going to share my screen. And can folks see that? Yes, great. Okay.
okay. Yeah, so we have gone through, people were great getting us data, and we have gone through and just tried to update everything. You'll see, I'll try to move through them fairly quickly. I couldn't resist giving some of the 3-year data visuals, but some of it's kind of hard to see all at once. But this is Jefferson Healthcare's, and they this is all so from September of 2020 through August of 23, and you can see this is their total ED encounters. The blue is non-SUD related, and the yellow is SUD related, or I'm sorry, not SUD, behavioral health related. And so you can see that their overall visits have increased by about 70% over this 3-year time period. And those behavioral health related visits have increased about 7% at the same time. And you can go to the next slide, Lori. And then we wanted to look at just what's been going on the last year. And in the last year, you'll see it's looking a little bit different. Total ED visits have increased by about 40%. And behavioral health related encounters account for about 6% of the total on average. And then you can go to the next slide.
Sorry.
Yeah, okay, so this is this is Jefferson Healthcare, but this is looking at just that percentage of behavioral health encounters. That was the small percentage before, and now are trying to show what that looks like. And you can see that while ED visits increased over 70% over the last 3 years, behavioral health encounters overall have increased by about 15%, with mental health accounting for the vast majority, and increasing by over 40%, whereas the SUD and SUD plus mental health related visits have declined. So and then this year this pie chart just shows it in a little bit different way, that the behavioral health encounters and how they're broken down, showing that the majority is mental health, with the next one being SUD, and then a small pie being both. And now this is the Discovery Behavioral Health data, and I cut this a little bit differently. So each of these chunks of time are years. So this 392 is their total contacts in that period of September 2020 through 8/21. And then, so all the red bars are total contacts. And then we've broke down basically that red bar into ITA investigations that were detained, ITA investigations that were not detained, and then crisis interventions. And so you can see the vast majority of their contacts are crisis interventions. It's about 70 to 75%. And that overall their annual face-to-face contacts have increased by about 16% over the last 3 years. The next one, and this is the same amount of time. And you can see this is just the month to month now to show the huge variation they have from, low in 7 of October 2020 up to a high of 60 in March of 2020. And just the variation by month of their face-to-face contacts is pretty incredible. And now this is just the last year. So you could see how just this last year looks. And their total contacts have increased by over 9% over the last year, again with some significant monthly variation, ranging from a low of 25, so not quite as low, in July 2023 to a high of 46 in June. So interesting, the high and low were so close together. And about 72% again were crisis interventions for this last year. And then we just looked at what their referrals were in terms of their voluntary referrals. These don't have anything to do with the ITA investigations. This is just for their voluntary referrals. And they most of them fall into this other category, which the interesting thing about that is they have very few referrals that are ending up to STD treatment, voluntary inpatient, or mental health outpatient. It's 1% is for STD, 4% for inpatient, inpatient triage or crisis stabilization. So it's pretty low percentages that are actually into some of those programs. It's interesting to me because 3 years ago, we'd started out thinking about like what kind of facilities you might need in your community. And it seems like those percentages are staying pretty small in terms of who's getting referred to those kinds of programs. And then this is East Jefferson and Port Ludlow Fire and Rescue. And this is the chunk of time that we have updated data from them, which is, combined data for them, which is from March of 2022 to August of 2023. And you can see that their total calls increased by about 7%, while during the same time period, behavioral health related calls declined by about 12%. So again, the orange bar is total and the yellow is behavioral health related. So you can see the differences there. And then we wanted to look just over the last year, and total calls have increased by about 20% over the last year. And behavioral health related calls have increased by about 100%, which it's small numbers, but interesting. And then the behavioral health related calls overall, you can see that line. You have to look at the two different scales because that line's not really to scale, but it shows about 5 and 12% of their total monthly calls are behavioral health related. So you can see the variation by month of what that percentage looks like. And the yellow squiggly line goes across. And then just in the last year, they had a total of 373 behavioral health related calls. And then again, to break down what those look like, again, majority for them are mental health. And then alcohol is the next one at 27%, and then opioids and other drugs. Actually, other drugs are higher than opioids. And this is just a snippet from the Quilcene Fire and Rescue. We don't have as much data over time from them, but you can see too that about 83% of their calls are mental health, and then they had about 17% alcohol, and none that we could find were coded as opioids or other drugs. So it was mostly mental health and alcohol. Same with Brennan, a little bit higher for mental health for them. It's about 92%. And this is just from March of 23 to August of 23. So it's not the same time period, but this gives a picture of what they're seeing, and it's mental health and alcohol for them. This isn't perfect because it's changed. So Olympic Ambulance is now doing the interfacility transports. And so we have a gap in some of the data, but I just wanted to show you this first slide is when EJFR was doing the transports. This was kind of the monthly transports they were seeing. And now Olympic Ambulance, you can see that they have about the same average per month is about 5 to 6 per month. The range of from 1 in March, which I was a bit surprised by, but to 14 back when EGFR was doing it. So it's a range, but they do average about 5 to 6 a month. Okay, now we're getting into the data that's wrong. So this is actually combined Jefferson County and Port Townsend, and I said it was Jefferson County. So so combined, Jefferson County Sheriff's Office and Port Townsend had about 2,053 behavioral health related calls last year, and over 50% were mental health or a combination of mental health and drugs and or alcohol. And the important thing to say about this, and unfortunately now I'm gonna have to get you the Jefferson County slide because yeah, this is my mistake. This should have been combined and then I should have had a Jefferson County one. But I could tell you Jefferson County, I just did some quick calculations. They had about 750 calls, and they had 428 of those were drugs, 180 mental health, and 86 were alcohol. So you can kind of see it's a similar breakout. Well, actually, so it is a little bit different. So I'll get you that slide for Jefferson County, and I apologize, Brett, for that. But this is the combined look at those. And the interesting thing, if you go to the next slide, Lori, this is Jefferson County. So when you look, I said 750. So Brett went through and hand counted this last year, and it's about 750. That's correct, right? Brett, is for Jefferson County. That's in line with what you think now, right? Yeah. Yes. Around that. And in the past, this is what we had been seeing in the past, which is very different. So it just goes to show you how important it is to be able to figure out this data. So the numbers are changing drastically when we have them hand counted and really look at each case individually. So, and if you'll go to the next slide, Lori. So this is Port Townsend. They had a total of 652 behavioral health related calls in last year, and over 60% when you add in the mental health and drugs and alcohol together, they had about over 60% were related to drugs in some fashion. And again, when you go to the next slide, so their total is 652. And if you go to the next slide, Lori, in the past, their total had been, much, much lower than that, around, what is that, about 60 or so, or 70, 80, something like that. So anyway, drastically different, depending on the year. So Believe in Recovery, the most interesting thing I saw on this slide, and I would love Gabby's insight on this too, is the percentage of clients that were diagnosed with opioid use disorder increased by nearly 90% over the last 3 years. So the way this data is laid out, it's by alcohol is in 6-month increments. The bars are basically 6-month increments. So you can see over the 3 years what's happening with the diagnoses. And so both opioid is really the one that has shown the biggest increase. And when you break them all down, you have about in the last 6 months, if you just look at the last 6 months, about 19% were diagnosed with alcohol use, 47% with opioid, 23% with methamphetamine, and 4% were other STD. And now this is Jefferson County Jail bookings, and the total bookings, which is the yellow column at the end, have increased by over about 14% over the 3-year period that we've been collecting data. And SUD charges, so drug and alcohol charges, not the reported substance use problems, but those that were actually booked on alcohol and drug charges, is down by over 200%, which I think we know some of the reasoning behind that. But then looking at those that report substance abuse problems, they're also down by about 100%. And then for mental health, it's up by about 100%. And again, there's so much variation with these small numbers, but it's interesting to look from when we started to where we are, just to see what those variations are. And Lori, if you can look at the next one. So this one shows those bookings related to drug and alcohol charges just by the percentage of them. So percentage of total bookings. And if you look at just the last September through August, so it's gone from about 25% to 19%. So it's about a 30% decrease in bookings just in this last year. Where if you look at the next slide, Lori, I believe it is. Yeah, so then when you look at substance abuse reporting, and this is the trick with all the variation, if you look just from September to August, it's went from a 61% of total bookings down to 14%, which is like a 300% decrease. But again, there's so much variation by month. It's in small numbers. So, but it's just an interesting trends to look at the variation there. It's definitely on a decrease these last 6 months for sure. And then if you want to look at the next one, Lori. And this is mental health. So mental health has stayed pretty consistent over the last year. I mean, if you look, it was 18% in September, it's 19% now, and not consistent. There's a lot of variation, but it's only about a 6% increase in comparison to some really big differences in the substance use, which makes sense based on what we know has happened. But and so that is that. So I went through those quick because what I really want to do is be able to answer questions. So, and we can go back to any of those slides. Lori and I decided, how do we want to do this? Do we want to let people ask questions as we go? But I was afraid we wouldn't get through it knowing how much time we have. So, Lori, you are going to be monitoring to see if anyone had big questions.
Yes. So give me a second to do that.
Okay.
And in fact, I've got the putting this kind of, okay, so we have two comments, one from Adam. Putting this kind of data together as an end-to-end process is much more challenging than it looks, and that is so true. I think we are probably a rare county that has this kind of look, even if we're not sure of the thorough proper coding of things. I think that the fact that we've at least got a place to start from is awesome. Cherish Cronmiller noted that she's interested that given the synthetic meth, how many people may be presenting with mental health, paranoid, schizophrenic behavior, but are actually a result of meth use, whereas the old meths showed the scratching, bad teeth, etc. How is differentiation made between meth use versus mental health problems solely? And I hear that being a complicated question, which I'm sure we're not addressing in coding. And that's some of the discussion that we want to have also as we look into the next phase. Where is our time? Where are we going to get the most bang for the buck in terms of the time that we spend coding things and all of the people who have to code it? How do we make sure that can be done sustainably? I am zipping through. Okay, I'm clicking on the link myself to see if anybody's put anything. I don't see anything in the questions or the presentation.
I do want to say, Brett, I saw your other note. It seems like we might be off a little bit on that, but I will get that right because Brett has really done a great job of hand counting. So we'll get new slides out to people that make sure we have your data right. So I apologize about that.
No worries, really. In the scheme of how much got done, really,
I mean,
you do not walk away feeling bad about that. We're gonna.
Yeah, well, no, I just he works so hard at it, and it's just so we've been having this conversation about AI and how you can use it for data, and so we didn't use AI for this, but you know, you rely on some of these queries, and it's like, oh, it didn't pull from the right place. So I apologize, Brett. But the thing that is amazing about the data he did is just it just goes to show you how important it is to really look at the individual records like that, because it's a very different story when you're really looking at what the circumstances were around each of those. It's very interesting.
So I want to go through a slide that talks a little bit about developing clarity. And then what I'd like to do is come back to the presentation and perhaps take each entity that we gathered and just ask, does anybody have questions about the DBH data or about, you know, any one of these? And so let me just share my screen quickly on the slide that we put together. So we've been doing a lot of work here in the past 6 weeks or so, thinking about what is the next phase of data collection going to look like. And we had a data work group meeting, which you can see the video and the meeting packet that supported that, Padlet that people put some feedback into. But at the highest level, one of the things that came out is that we would like to identify specific population level questions for the data work group to address. And so we need to come up with a process to do that, and then figure out who's needed at the table to pursue whatever it is that we want to do. And I've got Dr. Karlbaum and Dunya Fol, who are meeting tomorrow together with me to start talking about what could that look like. I really appreciate whatever formal or informal leadership I can get from either of those entities on that. And of course, we're going to need more people in that conversation. But since it was Dunya that brought up this question around population level questions, I wanted to start with her and make sure we are efficient in how we're having the conversation at the broader level about what it is we want to go explore, go try to find data for. And then another piece that came out of that data meeting is that we want to define questions and where the data is to incorporate therapeutic court data into all of our data efforts. And one example of this that I appreciate Brett bringing forward is, for instance, if we had numbers around the drug courts, their entrance and graduation and recidivism of participants within 5 years. And apparently that's data that we could get from a nationwide booking tool. The question is, how do we support getting that done? How do we, do we need to pay somebody to do it? Is it somewhere already that we can just pull it? So that therapeutic court data is another piece. And then we've had a lot of discussion around law enforcement data collection really over the last 3 years. And I think what we really need to address is the sustainability. We can't have Brett going through everything, but you did see in the presentation the difference between Brett going through everything and us leaving it, where it has been, with people boots on the ground looking at it. And Brett has noted, maybe we could get some administrative help that we train to be aware and able to go through and code the data. And perhaps after doing it for a few months, they would get pretty good at it. So the time investment wouldn't be as deep as it is now. So how would we fund that? Those are things to think about. And then maybe at the very basic level is exploring how can we train our forces that are on the ground, both in terms of law enforcement and honestly EMS as well, so that our coding is consistent, and find out where is the bang for the buck break on that. How much are we trying to require from boots on the ground, and how much are we expecting the administrative potential administrative support to give us, and going back and looking at all of those calls. So those are some specifics around what we've been thinking about for developing clarity on our data effort going forward. And now that I've given you that overview, I'd like to go back to the presentation and just, Lisa, if we could look at the first bit of slides. I think they were around Jefferson Healthcare. You can see what the outcomes were, or what the insights were that we generated. I'd love to hear feedback. Adam, do you think that was accurate? Other folks, what does that tell you? And I'll leave it to Lisa. Okay, I'll be quiet now.
So are you going to go back to those actual slides?
Yes,
Lori?
I am. And give me 1 second to get that done. Here we go. And I can flip around to whatever slide people are interested in thinking about.
So I don't know if you want to go to one of the behavioral health specific slides. Yeah, I don't know. Maybe yeah, just shows kind of what's happening just in the behavioral health field. The variations, again, it's very interesting when you look at it by month. Looks like just somebody might have their hand up, Lori.
Oh, I'm sorry, Lori Tinker.
There I am. Adam York, I would assume your sticky fingerprints are all over this data. And I was curious if you feel like you were adequately able to find a resolution of getting an accurate count of behavioral health encounters when people present in the ED. I know it's always, historically, it's been a problem that people present complaining of a physical problem, and then secondarily, the physician or provider will recognize or address a behavioral health problem. But sort of what goes in the coding is the, you know, the first in, which is the medical problem. Do you feel like that's been addressed so that these numbers are close to accurate?
I went around this block a lot when I was
I'm
first
sure you did,
learning
yeah.
this, and actually you were one of the people who helped me get acclimated to the ED data when I was very first starting. So happy to talk with you for a minute. The way that, so speaking to years ago, you and I don't want to mention names, but you know, some other key players in the emergency department, and who work with like behavioral health, I think the social workers, we decided to, there's a lot of ways to skin the cat, you know. We decided the most consistent, best way for our purposes was to just focus on the primary and secondary diagnosis code. So when I was pulling out, you know, behavioral health related, SUD related, I would, you know, first check the primary diagnosis, then check the secondary diagnosis. I'm drawing a blank right now, but I also often look at clinical impression, and it usually matches pretty well. So I don't remember if I did that for this data set specifically, but it's the other key, one of the also other key things I look at. So yeah, so if someone comes in with like a broken leg and, you know, a behavioral health thing is their secondary, that'll also count as a behavioral health visit because it was in one of the top two.
Alrighty, it's a very tough nut to crack, I know. And yeah, they came in with a broken leg, but they have a broken leg because they fell because they were high. You know, but sounds like I do remember your eyes sort of glazing over when we first talked about it. But it does sound like you're working on it, and it's good data. So thank you.
Yeah,
thank you.
And it has been fairly consistent over the years. So that's the last thing I'll say. I mean, as far as the way we've done it. So yeah.
Thank you. I'll move on to Discovery Behavioral Health data. Is there any observations or comments, questions? And Lisa, tell me if there's another slide you think it would be good to.
I mean, I think this one gives a good picture. I'm trying to think. Yeah, you can. Is someone here from Discovery? Oh, there's Jim.
We have Jim and Andine.
And Jim, I did work with Christine on this yesterday a little bit to make sure that we were capturing the right numbers. It seemed.
I want to thank DBH and just the access to Christina. I think that has really helped us feel good about what we're putting forward here. Okay, if there are no questions there, I'm moving on to.
Lori, I had one quick question about DBH data. I wonder about zooming in on the DCR evaluated patients or the ITA evaluated patients. I think the ratio of detained and not detained would be very interesting, right? Because the goal is the least restrictive environment possible for people to begin their journey towards health. And I just wonder if looking at that at a monthly maybe or quarterly might be interesting. Because I think that's a different population than the population that's the non-ITA patient.
So in this slide, you can see that there was 22% of their contacts were ITA contacts, and they were about split evenly, those detained and not detained for that period of time.
So I could say moving forward, this is going to change a bit with the state doing more mobile crisis response. So you're going to see more crisis intervention occurring and maybe keeping people from getting to the ED that, you know, are really non-ITA type patients. Traditionally, in the 4 years I've been here, the number of ITAs that we actually do are very small. Because you're right, least restrictive environment is really what we're always shooting for. And on top of that, finding a hospital bed is always difficult. It's the other complication. But what you see is, pretty typical. We might, and I know people will notice the change in numbers, and that's crisis. I mean, it is up and down. I mean, it really is a firehouse model per se. Where we are there to serve, and you never know when a crisis is going to occur, or when you can have a month where it's really low, the next month it's real high. So the data is always going to be looking like a roller coaster. That's pretty typical in all the years that I've done crisis. It's just, there's no really steady onslaught. But I think the number of ITAs hopefully will slowly actually even go down a little lower as we do more mobile crisis outreach and actually meet people where they're at. And that's what the hope is, as the state's starting to invest more money into that. Hopefully it'll make it to us. That's all I can say there. So,
thank you, Jim.
Yeah.
Moving on to East Jefferson Fire and Rescue, along with Port Leadville, they're combined here. Questions, comments?
I have a question for you. This is Apple. I'm wondering with calls, the discernment of, say, what we were discussing with Adam relative to Jefferson Healthcare data, is the call defined by, what is marked when the call comes in, or is it marked after addressing the call has occurred, such that you might find that there's a secondary need? I'm just sort of wondering around the definition of what a call is, and if we're bleeding.
Yeah. I'm happy to explain that. And Tammy's on the call now. She's the MSO, or the supervising paramedic for East Jefferson, but I think she's driving, so I'm going to answer. This is provider impressions, both primary impression and secondary impression. We have been trying to coach providers. If someone calls for is in a car crash or stabs themselves, but it's because they were using a substance that was making them psychotic, to code that behavioral health component as secondary to the primary complaint. But you're absolutely right. The reason for dispatch is captured in the charting system. It's frankly not very accurate because people aren't healthcare providers, and they call with the broad complaint, shortness of breath, chest pain, unconscious, and that can be quite variable and different than the provider's impression. So these are provider impressions.
Great, thank you for explaining that.
Yeah. I still think there's opportunity to improve, sort of how much energy, when busy providers are trying to deal with multiple incidents and get back in service versus spending time charting. There's a balance. So we'll continue to encourage people to be thoughtful about their sort of the root cause of the patient's need for help.
Dr. Carbon, I have a quick question. So do these calls log the calls that maybe my DCRs make to have somebody transported to the emergency room for evaluation?
They are in this, they would be in this
Okay.
data. Yeah, because I just did an aggregate poll. So
Okay.
yeah, they would be in this data. The patients that are evaluated by the CARES team are not in this data because CARES is not dispatched and doesn't chart in the East Jefferson charting system. They chart in a separate charting system provided by Believe in Recovery. And so I don't have access to that.
Is it something going forward that we should think about so that we have a better, fuller picture? How can we get CARES? And maybe I should be asking Tammy this, or Gabby, or you tell me.
I actually did at your last PIMS report or whatever, I actually did put in CARES data into that report.
And it was under EJFR, right?
Correct.
Yeah. I know I remembered that we had data from you. So in general, if we were to continue then collecting what we have, and maybe it's because we only have such a short amount of data, because that program is only started in the last 6 months or whatever, maybe that's why it's not in there. But it sounds like we want to aggregate, is that the right word? I'm so not a data head. Yeah, we want to put both of those sets of data together so that we get a full picture of it.
Yeah.
And thank you, Gabby and Tammy and everybody that's collecting that data now. And Gabby, do you feel like it's pretty well coded? And I know we haven't dived into it, but how are you feeling about it after the first however many months that the program's been going?
I think it's going pretty well. Data collection is actually relatively easy with our platform. And it was pretty straightforward to put the data into your spreadsheet. So maybe having a different, because I don't know if Chief Black or somebody put additional data into your spreadsheet after I had put data in there. So maybe having its own
separate bank.
So yeah, and I think I told you that before. So that would be my only suggestion moving forward, is just to have that extra tab in there.
That makes sense. Thanks, Gabby. Moving on to Quilceen's fire and rescues data. Any questions, comments?
Dr. Kalba, it was interesting that they didn't seem to have anything related to SUG. Drugs really in their data, and I just didn't know if that was a.
Yeah, and I'll let Chief McKern maybe provide more details, but
sorry.
I think the computer program they're using before October 9th didn't have as many options for multiple provider impressions. And so it may only be the primary impression.
That is correct. You just answered my question. There it is. We're on a new system now. Providing that we can get the data out of the new system, I feel your pain for what you and Brett have to go through. And as a matter of fact, I just did my month-end report for October. And Brett, I did the same thing you did. I had to count one at a time and move every bit of data across. And so I know we paid fairly good money for this new program, and I'm hoping I can convert it and make it work for us. So let's hope. I think so.
That's helpful.
We are tracking our CARES data with our regular numbers. It's not a separate system.
Okay.
Oh, that's good to know that it's actually in the system.
Yeah, it's in the system.
And so in another 6-month time frame, we might actually have as we get used to this new system, I don't know how long ago it was put in, but that should give us perhaps better coded, better idea of what's really going on the ground.
I think give me the first 6 months of 2024. Right now we're kind of in a trial process. I'll tell you for 23, I'd like to finish up 23 and get the bugs out, if you will. And then I think first 6 months we'll certainly take a look and improve our data.
Okay, thank you. I appreciate all the work you're doing on it. I know it's a big undertaking.
Lori, if I could add that, there is a possibility I need to check the pricing to have sort of what's called a parent account. So as the medical director, I could have an account that pulls data from Brennan, Quilcene, and East Jefferson, all three, into one spot. So I could get aggregated data.
That would be huge.
It may cost additional money, and I'm not sure the EMS Council has additional funds right now.
But maybe it's something that we as the consortium could figure. I mean, I don't know what sort of amount we're talking, but if we figured out what the cost was, would it be worth it for the consortium to support something so that we do get that fuller picture from a more aggregated perspective of our fire and rescues? Brennan, I'm looking to see. I don't have anybody here from Brennan.
You can just take my report and echo it because we're all doing the same. It's the same discovery. And the good news was that we will be adding Discovery Bay to the 3. So Brandon Quilcene Discovery Bay should be a 3-way because we're trying to match all the data together. So again, have patience with us as we truck down the good news is that the same individual that's doing ours is also doing Brandon's, and it's also doing Discovery Bay. They're using one of our officers that we now call Mr. ESO. We've changed his name and all of that. So I do like the idea of what Dr. Carwin just said, which is, I think you used the word parent. And the only thing I can say, Dr. Carwin, good luck. I think you're going to need it. And I don't know if there's any money in the world that's going to be put this together, but good luck. I can tell you that.
Thank you. I noticed that Adam has put a note in the chat. And sorry, let me just move this out of the way here. Interfacility transports, any questions, comments, insights? Gonna blaze pretty quickly here as we get toward the end of our thoughts, Brett, around our law enforcement data. Any questions, comments, insights from others?
The other thing I wanted to say that didn't get on the slides is when we removed the traffic and parking kind of data from the total calls, and which resulted in combined Jefferson County and Port Townsend making it their behavioral health related calls make up closer to 30%, when before we were saying somewhere between 2 and 7%. So it's a much bigger percentage of their calls than we had. And I remember long ago when we first pulled that data being really surprised. But when you pull out some of those things that are, just routine traffic stops, parking tickets, and you're just looking at all the other calls, it makes a very big difference. So that's a big chunk of their calls that are going towards behavioral health. Right. And I can, when we update these slides, I can put a little slide in there that shows that difference too.
Perfect. Commissioner Burlington.
Yeah, I was confused a little bit, maybe because of this slide, the data issues, but how many behavioral health calls did the Port Townsend police have? Because I thought you said it was like 750 for the sheriff's office.
Port Townsend is the next one. It's 652 for Port Townsend is the total. And I think we've got to look at Jefferson County again. I will get an updated slide out. I totaled something I shouldn't have totaled. So I'll get it all cleaned up and out to everybody. So
okay, thank you.
Yeah, I can tell you this one is accurate. So this data, we were paid to go through it. So like, gosh, 8,000 calls for service, I think I went through. And then each one, I methodically went and changed each one. So this data is correct. You will see that the Jefferson County data later will be significantly lower. And this is not because of that we have less contacts. We have actually we'll almost have double the calls for service than Port Townsend does. But it's just that the coding is a little bit worse. And that's mainly because we audited the Port Townsend one.
Moving then on to, let's see, we have PTPD, which we just talked about. Believe in recovery. Any comments, insights, questions? Going once, going twice. Moving on then to the jail. Questions, comments, insights?
Where was the, Lori, can you go to slide 21, I think? Because I think it gives a little bit of, it shows just all of it in one spot. It's a little bit easier to. And this is over all 3 years, but it just kind of shows the variation.
I want to acknowledge we're at 3:59 right now, and I'm in your calendars until 4. We can certainly stay and continue this conversation, but I want everybody to know that I understand you might have other things you need to move on to.
That's pretty good though, because we're at the end. So
we're at the end. One of the things that I will be reaching out to you folks individually on is there is a $100,000 grant potential opportunity. It's for a rural health network program development grant. It's just like the grant that we started out all those years ago when we first had just 4 little members that were the nucleus of what started the Behavioral Health Consortium. We are considering that, when I say we, that would be me. I know that we could anchor it at Discovery Behavioral Health. We could use it then to do, let me find the slide that quickly overviews the grant. We could use it in the way that the sustainability group had sort of identified 6 months ago or whatever it was, when we were looking for a grant that would support us to go through and do some actual strategic planning. The other thing that I like about this grant is it has a health, social determinants of health sort of perspective that we can then justify. We're using that grant in connection with opioid settlement funding to both look at substance use disorder and to address some of the aspects of the social determinants of health factors that that sort of play back and forth across these landscapes. So it's something that we're thinking about. I'll reach out to you folks individually. If somebody has some deep reservation about it or some real idea of what they'd like to see us focus on, I invite you to write that in the Padlet that is that you all have the link to. And because we won't be meeting again until February 8th, this grant application will, if we go after it, it will be due before I come back to us all as a group. But I'll be sure to keep everybody in the communication loop as that decision process unfolds. Are there any other thoughts that people would like to get in before everybody starts jumping off? And then I still invite folks that would like to stay and talk any further to do so.
Lori,
Lori,
it's just,
I think we
I
should
just wanted to
go
say-
for that. Oh, go ahead.
Oh, I just want to say thanks, Lisa, and everyone who fed data to Lisa, and thanks, Lisa, for your integration. That's amazing.
Absolutely. And I was just going to say, I think we should go for that grant, but then we should use the first part of it as a celebratory dinner, because that grant is to do what we have already done, which is to establish a really good community network in this area. With kudos to you and your diligence in keeping us together and moving us forward.
Couldn't have been done without everybody at this table. And here's what I will say, that grant, we could look at something that's youth focused, we could look at something that's elderly focused, that crosses back and forth between this area that we've already got some funding with the opioid settlement funding. So I encourage folks, if you're inclined to think creatively or would like to get together in a discussion, reach out to me if I don't reach out to you immediately. And then okay, so I'm going to close that out. Any other comments? Feel free to leave if you need to. If you'd like to still talk about data, we'd like to talk about it with you. And if not, go forth. Have a wonderful afternoon. Thank you so much for your time. We'll see you again in February. I'll be sending out an invite later today for that.
You might consider this meeting needs to be just slightly longer since you're meeting less often. Let's to hear that, but
if I put it in people's calendars for an hour and a half, will you still accept it?